everyone. Welcome to our very first lab on the skeletal muscles. In this particular lab recording, I'm going to have to do the muscles of the axial skeleton, the axial muscles mostly, with the exception of pelvic floor. We're going to basically do this lab on the muscles of head, neck, and torso. Then we'll be focusing on extremities, upper and lower, and pelvic floor in the next video, and then have our exam. Now, what we want to start off with is some basic description of what it is that we're doing. Now, I will talk about this more in detail, so don't really worry too much right now. I just want to we are going to look at muscles, like I said, axial and appendicular musculature. One of the things we will talk about is mostly superficial muscles. Remember, superficial is the anatomical term. That means we are closest to the body's surface. Intermediate, meaning in the middle, or deep, meaning close, further away from the body's surface. So we especially discuss superficial and deep in chapter 1, I know in my lectures. Now, one of the things that I also want to mention is we will be using a lot of models, looking at origins, insertions, and actions. And one of the things I will always do is at the end showing you the ones you want to make like note cards about and really practice. There will be some multiple choice questions dealing with this. This one will be 30 and 20, 30 identifications and 20 multiple choice, where the 20 multiple choice, and this is the format I will use from here on out. The first two exams don't fit for this at all, but all the rest of them do. For example, that will be the true if you even had me through A&P2 labs as well. This will be how every exam from here on out, 30, 20. 30 identification, 20 multiple choice questions. And there will be some tendons that I discuss as well. But as we get started, this is what I want to do is discuss the words origin, insertion, and action. Now, to discuss these words, I'm going to do some very rudimentary, simple, basic drawings here. And the simple basic drawings that I'm actually going to do, let's say I have a joint here, okay? Let's just say we have an articulation here, or let's say, for example, humerus and ulna, for example, forming the elbow joint. Now, with these two bones, you would have a muscle located here, and this muscle, for example, would have to have two attachment points in order to produce the movement that we need to produce. And these attachment points here of that muscle, so generally in my lectures I always talk about that there's a muscle belly, and the muscle belly is the portion of the muscle that does the movement. And on each end there will be tendons. One of these here, when this muscle moves, we produce a movement called an action. Action is the movement produced by a particular muscle. And the reason I'm doing this is when this muscle here contracts, and we would see that this muscle here would contract, and the attachment point that it has where there is no movement produced, as it was the anchor that holds when the muscle produces movement, is called the origin. And the portion down here where this muscle attaches here and does move that structure is its insertion. So every muscle has an origin. They may have one or many origins. They may have one or multiple insertion points. And when the muscle contracts, an action is produced. So all muscles have an origin, insertion, and an action. So the terms origin, insertion, and action are the kind of the first terminologies we're learning here to understand what's going on in muscle anatomy. Muscles have attachment points. As we said, the origin, now it's usually on a bone, but there can be origin points that are on soft tissues, ligamentous tissues, skin, for example, especially insertions. But it is the part that does not change position when the muscle contracts. The origin would be like its anchor. It doesn't move. It does not change position when that muscle contracts, where the insertion does. Now, it's the attachment point, again, usually onto a bone. For us, there are, again, some soft tissue insertions, things like that, where it does change position when the muscle contracts. So that is when the muscle contracts, there is a movement produced and the insertion moves. When that movement happens, that is called the action, the movement of a body that is produced there. Now, what I want to help us to do is this is the list of actions that in lab we're going to do. There are some other ones I do in my lectures, some extra ones, but we're going to discuss and define each one of these. Now, there are no images described here, and I will be using some sketches to help us visualize the various different movements of the body, so we'll come to those momentarily. Now, flexion and extension. I always like to do these guys in pairs. Flexion, extension, okay? Flexion and extension, and then we'll do hyperextension. Now, one of these things that we want to talk about is, guys, if we had a straight line here, and let's say I drew this guy, and that way we know this is a perfect 90-degree angle here, 0 and 180 degrees. Okay, that we have some angles. Now, with these angles in play, if you were to start here at 0, which is the lowest number we can have, and let's say I'm going to use green, and we move this way where we are making the angle get bigger, an increase of the angle, okay? Or vice versa, we can go this way and decrease the angle between two articulated bones. Now, that is two movements that we can produce. Flexion reduces the angle between two articulated bones. So here in red, we are reducing it. That is flexion, okay? And here I'm increasing and opening it up. That is extension. Now, remember, so what we see is flexion reduces the angle. If I go from 90 to closer to 0, that angle like 90, 45, 0. Or if I'm going 0, 45, 90, I'm increasing when I go that way. Now, another thing that I could do is I could continue to extend even further. Now, let's say that 90 degrees, let's say this was the anatomical position. Anatomical position. Let's say that was anatomical position. And the body kept extending past anatomical position. We call that hyperextension. A hyperextension is extension beyond anatomical position. So if you take your chin and tuck it to your chest, you are flexing it. If you take your head and raise it to anatomical position, you're extending it. If you tilt your head back to look up at the ceiling, you are hyperextending it. So flexion, extension, hyperextension. These kind of all go together very well because these are types of angular movements where flexion movement that reduces the angle between two articulated bones, and extension movement that increases the angle between two articulated bones, and then hyperextension is extension way past an anatomical position. Now, let's also talk about adduction and abduction. Adduction, abduction. Now, I oftentimes hear when I am teaching this in the classroom, I really just keep it simple. And if we take our arms here, let's say, for example, and we move it away from midline, or we bring it back to the midline. You can raise your, lift your arms up or bring them back towards you. When you are taking them away from the midline, you are doing what is called abduction. When you are bringing them to, you're doing what is called adduction. Okay? Think add to. Now, what happens when someone gets abducted? They are taken away. Okay. When someone has been abducted, you are taking them away. Okay. So what we are dealing with here is that when an adduction is movement towards the midline, and an abduction is movement away from the midline. Now, protraction and retraction go together very well. Protraction is movement anteriorly or forward in the horizontal plane. What is a good example of this? Well, a very common example of this is when we take our mandible and stick our chin outwards, like when you protrude your chin out, when you want to stick it out. Or when you take your head and push forward, like stretching it, like when you watch a chicken bob its head. Now, protraction, retraction is movement posteriorly in a horizontal plane, moving backwards. So that would be like taking your jaw, your mandible, and pulling it backwards, sliding it back. So now, elevation depression. Think of elevation depression. Now, elevation is movement upwards, like when you bite down with your jaw. When you take a bite and you bite down, you clench your jaw. You're elevating it. You're moving the jaw upward. You're moving your mandible upward so your teeth can compress against those of the maxilla. Depression would be when they drop. Think like if you see a bad grade on the grade book on D2L, on Brightspace, and your jaw drops. I can't believe I did that bad. And your jaws drop. That would be depression. That would be lowering it. Movement downward in an inferior downward direction, like when you drop your jaw. Okay, elevation, depression. Circumduction is rather difficult to describe and draw anyway. It's easier enough to describe. And we have to kind of think of rotational movement. Now, while you're listening to this, what I want you guys to do is just take your left arm, stick it out, and with your finger, I want you to draw a circle in the air. Now, while you're drawing that circle in the air with your finger, you are doing circumduction. Now, why is this? Well, the head of the humerus is not spinning like a doorknob in the glenoid fossa. It is making a circular motion. Movement of a distal end of the bone that describes a circle, but the shaft of the bone does not rotate. So, like when you turn a screwdriver, when you turn a doorknob, that would be rotation. But the head of the humerus isn't doing that. And normally when I teach this, I have models in the anatomy lab, and I can show them. I pull out our skeleton and show what I mean by that, but I can't do that here. I'm at home. I come in and grab models and bring them home so I can video them. Now what I'll do here is at the end of this, I will pull up my A&P1 lecture notes and show you guys. We just did this in my lecture. So now what we want to talk about, guys, is your rotation. Rotational movement is pivot on an axis, kind of like turning a doorknob. A good example of rotation is when you shake your head no. Pronation and supination, these are movements specific only to the forearm because the radius and the ulna, the head of the radius, can rotate in the radial notch of the ulna, and as they rotate, you can twist your forearm. So when you reach out to turn a doorknob, and next time you turn a doorknob, you're doing supination and pronation to do that. Now, the first thing I want you guys to do is to hold your left arm out. While you're doing that, hold it in an anatomical position with your palms facing outwards. Then what I want you guys to do is take your palm and rotate it down. That is pronation. Palms down or even posteriorly. Turn it all the way to the back. Palms turned downwards. Palms on the ground. Pronation. Palm down. Pronation. Turn your palm up now so that you could drink soup out of the palm of your hand. And that would be supination. Turns the palm upwards or anteriorly. Okay? Now, inversion and eversion, these are specific things that the foot does. When the foot does an inversion, it turns inward. That would be like taking your medial side of your foot, your big toe, and twisting it in towards your left foot. If you had your right foot, took your left foot, turned your big toe in towards the right foot, you're doing an inversion. If you take your pinky toes and point those to the left or right sides of your body laterally, that would be an outward turn of the foot. That's an eversion. Eversion twists the foot outwards at an angle, and an inversion brings the foot inward. Now, lateral flexion is specific to the vertebral column. This is like when you take your head from side to side. Like if somebody says, "I don't know," and they bob their head from shoulder to shoulder, or when you bend over, like if you guys do a stretch where you like windmill stretch kind of thing, where you take your arms and go over your head and then bend your vertebral column to a left or right side, stretching your lower back. Bending your vertebral column to one side, like when you bend your neck to the left or right to put your ears onto your shoulders. Or when you bend your vertebral column, your lower back side to side. Those are the ones that really actually can do those movements. Now, plantar and dorsiflexion go together. Plantar flexion and dorsiflexion have to do with the foot. Now, I always say, now imagine that you guys went out finally after you got through A&P and you got that big fancy job, and now you're making loads of money. And while you're making loads of money, you go out and buy that fast car you've always wanted. You now can go out and afford that Corvette or that Dodge Challenger, that Camaro you always wanted, that fast car. And you go get that and you drive off the lot with it, and you're going down motor mile with it off the lot, but you're excited that you got this thing. So next thing you know, you're going really fast, and you pass by the police sees you, they pull you over, and you're like, why did you get pulled over for speeding? Because you had planted the pedal to the metal. When you plant the pedal to the metal, when you push the pedal down, you're doing plantar flexion. Now, think about it. If you've ever heard of plantar warts, a plantar wart is a wart on the bottom or plantar surface of the foot. That means you're pushing the bottom of the foot down. Toes are depressed, toes down, like when you push on the gas pedal, when you plant the pedal to the metal. But now that you had the police officer on you, getting ready to pull you over, the siren goes on. He's like, woo, and he's got the blue lights on. You got Smokey the Bear on your back door. You better pull over, let off the gas, because Smokey the Bear's on your back door. Let off the gas. Dorsiflexion is when you let off the gas and your toes pulled upwards towards the shin, so the toes are actually elevated to the ankle. You're pulling your toes up towards the shin. Now, opposition is a movement of the thumb. When you take your palm and go towards your thumb towards the palm, like when you cross your palm, your thumb over your palm, I will get this right in a second. When you cross your thumb over your palm, like if you're doing the Boy Scout salute, and you cross your thumb over your hand when you do that, or you touch your thumb to your fingers. These, again, while making grasping motions, these are called opposition. When your thumb goes back, we call it reposition. Opposition of the thumb is movement of the thumb towards the palm or towards other fingers. Okay? Now, these are just terms you got to practice, and I'm going to ask some of these on the multiple choice section. I'm going to say so I may ask you guys things like what an origin is, what an insertion or action is. I'm going to ask you some actions. Now, another set of definitions that we need to discuss, and I will give examples that will be more applicable later, is the word agonist, antagonist, and synergist. Now, agonist. Now, a good way to remember the agonist is the muscle, I call it the prime mover. Now, what I want you guys to think about it is if you go to the gym, you probably will hear somebody when they're working out, they may say something like no pain, no gain, or no agony, no braggity. No agony, no braggity. The muscle that's now in agony when you do your biceps curls, when you do the flexion, when you're You can tell I don't go to the gym, okay? But when you do an exercise, the muscle that hurts the most, that's the prime mover. That's the one that did all the work, and it's going to be the one in agony. The agonist is a muscle who's chiefly responsible for a movement. Like flexion of the forearm, flexing at the elbow, is chiefly done by the biceps brachii. And extension of the elbow, extension of the forearm, is primarily achieved by the muscle called the triceps brachii. Now, there are a lot of others that also may help for it, so we're going to see helpers. Now, the agonist is the prime mover. Now, antagonist. So it is agonist. It is anti-agonist. It goes against the prime mover. It opposes it. For every agonist, there generally is an antagonist because that's the muscle that undoes it, because muscles only pull, they don't push, okay? I don't know any non-antagonistic pair muscle, okay? I only know, every muscle I know is an antagonistic pair. Now, what we will see, guys, is these muscles oppose the movement. Think about the antagonist is the bad guy in a story, in a movie, in a TV show, goes against your hero. He's the one that opposes that. So, for example, if the biceps brachii mostly flexes, and then the antagonist would be the triceps brachii mostly extends. We'll see like the teres major does medial rotation, teres minor does lateral rotation of humerus. The zygomaticus major actually elevates the corners of the mouth. The depressor angli oris depresses or lowers the angles of the mouth, corner of the mouth. Flexor carpi ulnaris, flexor carpi radialis is a wrist flexor, whereas a flexor carpi ulnaris actually adducts. They are in, so you can abduct or adduct these two particular muscles. The flexor carpi radialis abducts the wrist, flexor carpi ulnaris adducts the wrist. Sorry, right at the end there, I got a little distracted and had to pause. I got a message from my boss, so I had to stop, and I got distracted, so I apologize. Okay, so we did antagonist. Now, synergist. Synergy is kind of things working together, okay? So, for example, somebody can have a synergistic response. Let's say they take multiple drugs, and you're like, well, which drug was it that made the person stop breathing? Well, maybe it wasn't the one, but it was all of them together. Synergists are muscles that assist. They come in and they help. A synergist assists. This is a muscle who actually assists in the functioning of the agonist. So, for example, a great example is this. Though the biceps brachii is the agonist for flexion of the elbow, the brachialis muscle also assists, and also so does the brachialis, or brachioradialis, and the brachialis. Triceps brachii, as well as the anconeus, help to extend the elbow. Teres major and subscapularis do medial rotation of humerus. Teres minor and the infraspinatus muscles laterally rotate the humerus. So those are examples. Now let me tell you, on my exam, I am not going to ask examples of these pairs, only the definitions. These are here to help solidify. I always give examples of things when I teaching, okay? So as we go through the, just remember, that's one of the things we're going to do. Now, okay. Now, what we are going to start is head neck region. Head neck region muscles, we're going to look at these, and we're going to start off, and I always have words, diagrams, and I have models. We're going to start with the head neck region, looking at the muscles of the epicranium. Starting off with the epicranial aponeurosis, called the gala aponeurosis, some people call it, so the gala aponeurosis, the epicranial aponeurosis, the gala aponeurotica, if you like Latin, it's the tendinous collagenous sheet. And we're going to start with that. Then we're going to see the occipitofrontalis made up of a frontal belly called the frontalis and the occipital belly called the occipitalis. So let's go and look at a model. So here we have our model that I'm going to be using. These images will be, there are labeled versions of these on D2L for you guys, and you can practice with them. Our collagenous sheet here called the gala. The gala attaches the frontal belly or frontalis to the occipital belly or occipitalis. Together in total makes an occipitofrontalis muscle. So the occipital belly, the frontal belly, and the gala or epicranial aponeurosis. So that forms that kind of top collagenous sheet here. So that is our gala. Now, with the occipitalis, occipitofrontalis in total, occipital belly and frontal belly in total there, and the apocranial aponeurosis, or gala there, and you can see these diagrammatically here. Now I want to talk about muscles of the eye. Now I'm starting off with the orbicularis oculi first, and then I'll turn to an eye model, and I've got diagrams of that in a minute. So let's talk about the orbicularis oculi. Orbicularis oculi. Now what is the names of muscles are Latin, but they are incredibly descriptive about these muscles and telling you what they do and how they look, etc. Now, great example of this, the orbicularis oculi. Now, think about the orbits of an atom. You guys saw that they circled the atom's nucleus. They orbited. Oculi, ocular eye. So the circular muscle that encircles the eye is the orbicularis oculi. Now, we used to discuss its various parts. We no longer do. But the orbicularis oculi muscle surrounding the eye is the one you use when you want to close your eyes and purse string them. Now, extrinsic eye muscles, and we will talk more about these in A&P2. A&P2, I will talk about their actions as well and test on those. But right now, what I want to focus on is just the anatomy of these extrinsic eye muscles. And I'm going to use two models to do this. I'm going to start off actually with a really good model of a human head, where we're going to look at these muscles kind of in position, and then I've got a little model. Basically, it's exactly what's inside this taken out that I've got, that I borrowed from our lab, our teaching labs. So what I'm going to do, guys, is talk about the extrinsic eye muscles. These are muscles on the outside of the eye. Now, what I want to do with these is, generally speaking, and I'm going to pull this thing right off my head. I'm really bad to get out of range of my stuff that I'm trying to do. We're actually going to sketch these first together, and we'll draw it together, and then we'll come in and discuss them. Okay? So what I'm going to do is for us to learn them, what we want to do is just draw a circle. And then draw that here. Okay, so now this means this is this is anterior. This is the front. Okay, and this would be a right eye as seen from the lateral view. Okay, we're looking at it from a lateral view. This is the model that I'm going to use. Will be right eyes. Okay, so back here in the back, I'm just going to draw this, and then just above here, about here, we'll draw this loop. Okay, let me grab some more colors. Purple, and let's see, maybe I need brown here. Okay, so we're going to start off with the first muscle here, and I'm going to start here. I'm going to work my way up to it. And this muscle here is the superior rectus muscle, muscle. Superior rectus, as you could tell, superior because it's on top, and we'll even label that while I do this. Superior, inferior, of course, at the bottom. And it goes straight back, rectus. If there's a superior rectus, there is obviously an inferior rectus, okay? Now, that is something I am going to talk about. Now, what we also want to do is come underneath, deep to this, and take a muscle that goes deep underneath our superior rectus, and I'm going to label it up here as superior oblique muscle. Now, this, of course, is also superior oblique. It has a tendon that goes through a pulley, superior oblique. Now, since we are looking at the lateral side of this, okay, we have and I'm going to label it here, lateral rectus muscle. Now, if there is a lateral rectus muscle, then there obviously is a medial rectus, because it goes behind it. And I'm going to do ... here as well because it goes behind it. And this would be the medial rectus muscle. Because it line of sight, ... means it's behind it. Now, what I'm actually going to do here is to take my inferior rectus muscle here, and I'm going to take him and pass in a medial direction that way. And I'm going to take him and label him over here like this, because it'll make sense in a minute, called the medial oblique muscle. I think I accidentally said rectus in a minute. Not medial oblique, inferior oblique. You can tell it's been a long day. I am normally great doing these recordings during a weekend, but today I had to do this after work, catching up after all my tenure stuff. Okay, so this is our inferior oblique. Now, I want to now do the inferior rectus. Now, the inferior rectus muscle passes deep to that. So it's actually deep to the inferior oblique. And that's the inferior rectus muscle here. And I like to draw these muscles out. Really helps students to learn and understand them a little bit better. Okay? And color code them. Go in there and draw them out. This is a very easy drawing to recreate if you can draw those to help them attach to it. Okay? These are the muscles that move the eye around. As they move the eye for us to look up, look down, look left, look right, look in and out, down and out, and up and in, etc., etc., etc. Okay? All the different kinds of movements. So what we are now going to do is we have listed these muscles called extrinsic eye muscles, the inferior rectus, medial rectus, superior rectus, lateral rectus, the inferior and superior obliques. Now what I'm going to do, and I'm actually going to begin myself here with this model that has the head intact here. And this would here from above. Now, if you could obviously tell, this must be a superior rectus. We're looking at the top. Now, by the way, this is a right eye being looked at here. This right eye. This is a superior rectus muscle. Now, if this is a superior rectus, I'm going to pick him up and move him. Down at the bottom, you can actually see, I'm going to pull this out. I keep getting caught. I'm going to move my headset over here. Okay, there we go. Now you can look down here and see the inferior rectus muscle. The inferior rectus down here. Now, if we turn on the side, the lateral rectus, which I can't hold on to it and point. This is a little bit harder to do than it is in the lab. We have our lateral rectus. Now, if there's a lateral rectus, there must be a medial rectus. Medial rectus will be seen right here. Now, the muscle we're seeing here is the superior oblique. And then down here to see the inferior oblique, you want to look right here to find the inferior oblique. Now, what I'm going to do is I've got a model that takes this eyeball out and has it on a pedestal. And most of ours are missing parts of the cornea because they get dropped in the labs. They get a lot of wear and tear, even though these are fairly new models. They're teaching models from our teaching collection. So what I'm going to do is zoom in a little bit here. Now, one of the things that's easy to tell here, of course, superior rectus. Now, this one's kind of hard to tell because this is the medial rectus. And how can you tell? Is this tendon passes in a medial direction. So this is the medial rectus. Another way to tell is the angle of the nerve at the back of the eye. It always leans and it enters the skull medially. So this actually is the medial rectus. This is the lateral rectus, superior rectus, and then the inferior rectus. Now you can see the inferior oblique would continue to cover up. It would continue to cover if it wrapped over this, the course it takes. Okay. We can't really see that well here on this model. This model doesn't do the greatest job with that, showing that course of that model, of that muscle. All right. And those are extrinsic eye muscles. I do use this model for the test generally. I don't use this one. I just wanted to use, I borrowed it because I had access to it. Basically, I'm limited on what I can bring home in a certain bag, and I could fit it in a bag, and I did it. Okay. Okay. So what we want to do, guys, is now discuss, so diagrammatically, you can see all these. Now think of my PowerPoints as also an atlas to help you find everything. Models is what I use. I like three-dimensionality. I just don't think it's good to study anatomy in a two-dimensional static way. Put your hands on it if you can. So in my videos, you can actually watch it and go to our library and check these models out. Now, they're going to be very picky about this. You're going to have to follow some protocols with hand washing and things like that, dealing with COVID. Our campus is available. I'm there on I'm there Monday through Thursday from 8 a.m. at 8 a.m. and I have classes that start at 9. But if you guys ever come in there to the anatomy model section where the library is, you can actually go into the circulation desk and check out all these models that I'm showing you. Okay. Now let's look at muscles of the nose. And there are two of them, procerus and nasalis. Now, procerus so I'm going to zoom out a little bit. Procerus is at the top of the nose. Basically, we're going to see a little bit of the fibers of procerus right here. Procerus. Procerus tops the nose. Nasalis, its muscle fibers run sideways on the nose. This is the nasalis muscle, seen on this more superficial side of this model. Now I'm going to try to keep him, okay, I'm just going to let him rotate a little bit. Okay. Now, we're now going to look at muscles of the mouth. This is the hardest part of the muscles of the face. Muscles of the mouth, orbicularis oris, zygomaticus major, zygomaticus minor, levator labii superioris, buccinator, rasorius, depressor anguli oris, depressor labii inferioris, and mentalis. Now, let's start looking at these. Let's do orbicularis oris. Now, orbicularis oris is going to be the first most important muscle we find. Remember, orbit. That means it's like the orbits of an atom. Oris, mouth. It orbits or encircles the mouth. This is your kissing muscle. This is the muscle that puckers those lips up for a kiss. Orbicularis oris. Now, the next muscle on our list is our zygomaticus major and then minor. Now, major and minor here can be a little bit difficult because when you look at the real human being, the major sometimes is smaller than the minor, depending on how this person smiles. But the major is very low and the minor is a little higher. Major, minor, major, minor. The zygomaticus major and the zygomaticus minor. And sorry if you can hear my dog barking upstairs. That's another drawback to doing these things at home. Okay, so zygomaticus major, zygomaticus minor. They come off the zygomatic bone down towards the mouth, zygomaticus major and zygomaticus minor. Now, as we continue to turn our attention to those muscles around the mouth, we find the levator labii superioris. Now, that name says a lot. Levator, lifts, labii, lips, superioris, from above. This is the muscle that lifts the lips from above the lip. Now, the muscle levator labii superioris is right here. A lot of people will say it's this. This is not levator labii superioris. This is levator labii superioris oblique nasi. This is which is the longest named muscle of the human body. This is levator labii superioris right here. Levator labii superioris lifts the lips from above. It comes from under the eye down under zygomaticus minor here. Levator labii superioris. Levator lifts, labii lips, superioris from above. Levator labii superioris. Now the names are very hard to learn for most students, but I'm going to tell you they are more descriptive. So you need to use the kind of verbiage I'm giving you to really grasp it. Now buccinator, the next one, buccinator muscle, it gets its name, it means the bugler. If we find the zygomaticus major, right here is our buccinator, the bugler. When you blow a bugle, this is one of those muscles that you can use to kind of squeeze the buccal region, the buccinator, the bugler. Also, you could see the buccinator right here as well. But when I test on it, I've always labeled it here, buccinator. Now let's about rhizorius. Now rhizorius is going to be located just superficial to the buccinator. So if we find the buccinator, right here is the rhizorius. Rhizorius gets its name from risible. Risible means something's laughable. So when you laugh, you're like, ha, 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 ha. And imagine this would pull the lips back like when you laugh. Okay, so when you laugh and the little corner of your lips kind of pull back, that's the rhizorius. The rhizorius muscles fibers pull that backwards. Rhizorius. Now, what we're also going to see here is the depressor anguli oris. Now, what does that tell us? Depressor pulls down. Anguli, angle, oris of mouth. This is the muscle that pulls down the angle of the mouth. So it's going to pull the mouth down its corner here at the angle. So this is depressor, pulls down, anguli, oris, pulls the mouth down at an angle. Depressor, anguli, oris. Now the next one is our pouty lip muscle, depressor labii inferioris. Depressor labii inferioris muscle here. Depressor labii inferioris. Depressor pulls down. Labii, lip, inferioris from below. Remember, muscles can only pull, they can't push. So, depressor labii inferioris, levator labii superioris. I keep clicking that for some reason. Okay, and lastly is the mentalis. Mental, remember, is the chin. So here and here we see the mentalis. Mentalis. The mentalis, the mental region or chin, the mentalis muscle. Mentalis. Okay, so with our muscles of the mouth done, that is the hardest part over for the muscles of the face. I think that's always the toughest part for students. Now what we want to do is about muscles of mastication or chewing. Now, the chewing muscles, now there are muscles that we can count as used in chewing. Some people will say the buccinator, but these purely they're used for chewing. The temporalis and the masseter. Now, yeah, they move the jaw and things like that, but the temporalis and masseter. Now, to help you find the temporalis, we're going to turn this model to the very deep part of it. And I need to take I've got this thing at home, take a pair of my needle nose pliers and fix this. We have our temporalis on the temporal bone, on the side of the head, temporalis. Now, temporalis, the next one, as we said, was the masseter. Masseter is one of the major muscles for taking a bite. Masseter will be seen right here. This is your masseter muscle. Masseter. You could see the risorius attached to it. Masseter. Masseter won't be seen here. It's going to be associated a lot up to the ramus of the mandible here, where it inserts. Okay. Now we're going to be turning our attentions here to the neck. The platysma, which will be diagram only, our models don't have platysma, digastric, omohyoid, and sternocleidomastoid. So let's turn our attentions to the platysma first. Platysma, diagrammatically, it's this muscle here. Platy means flat. Now, it's not labeled, and part of me wants to say that our course removed it. That our structure sheets removed platysma, and I forgot to remove it from my notes, is what I'm trying to say here, and I don't remember now. It's been a while since I've been teaching mostly AMP2 for a while, and it's some things like that. Okay, platysma still is in here, but it for some reason wasn't labeled here. Is platysma. This is platysma. Platysma. Okay, and it's my fault for leaving that muscle out. I means sub. That is platysma. Digastric. Now, digastric, di meaning two, gaster meaning belly. Digastric. Now, I'm going to take the top of the skull off of this model. And what I want to do, okay, there we go, is to show you the digastric. Digastric, here is part of it here. This is one of its muscle bellies. Digastric has two bellies here and up in here. Okay. Up in the neck here. Digastric has two bellies. Digastric. Now, the next muscles that we're going to see are oftentimes called, this next muscle, the omohyoid, is referred to as a strap muscle. Omus, meaning shoulder, and hyoid. So this muscle comes down from the shoulder up to the hyoid bone. It is a strap muscle. Omohyoid. Now, one of the bellies of omohyoid is here. It's referred to the superior belly, and it goes under this very large muscle we're about to name, and then it takes a connective tissue loop and comes out here as its inferior belly. So there actually are two bellies of the omohyoid, here and here. Now, the next muscle, sternocleidomastoid. The sternocleidomastoid, I before E, except after C, and in words like sternocleidomastoid. The sternocleidomastoid, sternum, clavicle, mastoid process. Sternocleidomastoid, right here, sternocleidomastoid. You can see part of it here, sternocleidomastoid, okay? Fairly large muscle in the neck is the sternocleidomastoid. All right, and you can see all these muscles diagrammatically. Okay, now, before we move on, I always go down here and remind my students that from this section so far, there are two muscles that you will be responsible for with their origins, insertions, and actions. Now, we used to do, when I started here, we did all of them. Every muscle we did, all 119 muscles that we identified, we did the origins, insertions, and actions. And then we cut it down to a list of like 50. Now it's down to this table. And a lot of places don't do them at all. So our college was like, well, we do want to do these. And they simplified it quite a lot. Actually, our current dean is the one who wrote the original one of these, by the way. So now we're going to start with the masseter. Now, the masseter has the origin, zygomatic bone, temporal bone, origin, inserts on the mandible, actually the ramus of the mandible, and it elevates the mandible. Now, a good way to study these is make a flashcard and quiz yourself on it. What I'm going to do is, guys, now the exam questions on these will be multiple choice, so it is going to be some things, but there will probably be about 3 of them on the test, enough that it's going to hurt you if you don't study them. And the sternocleidomastoid, sternocleido, origins, sternum and clavicle, insertion, mastoid process. Well, what bone has the mastoid? Temporal bone. Now, this one's rather interesting. There are 2 of them. When only one contracts, it laterally flexes the neck. That means, or the head, it pulls when towards the one that contracts, it pulls the ear towards that shoulder. Rotates the head. It pulls the head, rotates it that way, like the pouty over the shoulder look when you're trying to give a selfie. Together, it just flexes your head. It pulls the chin towards the chest. So these are the first 2, and I always like to go over them in these kind of groupings, where I like to do muscles of head and neck. So masseter and sternocleidomastoid. Okay. Multiple choice questions on those. Okay, I'm going to go back up here. I don't want to go over every single little slide right now. It takes us 2 days to do all this right now this semester. It's rough trying to do it all in two classes, but guys, it is doable. Now we're going to start with the pectoral girdle. Now pectoral girdle, this means you're dealing with the shoulders where the arms attach and things like that. We're going to see the trapezius, levator scapulae, rhomboid minor, serratus anterior, pectoralis major, and pectoralis minor. Now, I wish the rhomboid major was also depicted here, but we just don't cover them both anymore. So I'm going to start actually with trapezius. Now, to start with trapezius, shaped as trapezoidal in nature, I've got this model. Trapezius is this large complex muscle on the back. Starting here, it's here, comes down, and down here. This very complex trapezoidal shaped, complex arrangement muscle is trapezius. Trapezius. You commonly know this as your traps when you're dealing with muscles of the like gym muscles. Levator scapulae. Now, best to see levator scapulae will be on my head and neck model. Levator scapulae will be seen on this head and neck model. So let's get this guy here and look at him, levator scapulae. To find levator scapulae, find the mastoid process on this side of the model. And right here where the transverse processes, the cervical vertebrae would be, we would come down and find our levator scapulae. A nice muscle here to cause a lot of neck pain when you're studying is levator scapulae. Give him a good stretch. I oftentimes like to put my head right about here and push to stretch him out when I'm working too much, like on writing, grading, things like that. Okay, so levator scapulae. Next, we're going to look at our rhomboid minor. Now, it is also going to be seen on this model here, rhomboid minor. Rhomboid minor is actually visible. So right here's levator scapulae. Come down here and find rhomboid minor. The major would be right under that. The rhomboids are found between the scapula's medial border and the vertebrae. Good muscles there that get sore and tense when you type, study, and things like that. When you're hunched over a computer, Those are the muscles that tend to cause a lot of burn. Stretching them out by pulling taking your, I like to grab my elbow with one arm and pull it across my chest to stretch some of those rhomboids out. But also you want to alleviate some of that pain, you want to pull those back and stretch out the pecs. And then also I like to kind of rotate those. And that'll help me loosen the rhomboids. So it also takes some of that tension off the pecs just to loosen that up, get a little less pain in there. But that's a good mid-back pain there. So stretching that out, I always like to just grab my elbow and pull it across my chest. I wish I could demonstrate some of these stretches. I always show my students because those are things that you'll deal with because you're going to have a lot of pain from studying. Pectoralis major and pectoralis minor. Now, starting up with pectoralis major, where are we going to find that? Well, let's grab our little torso guy here again. Pectoralis major. Now, pectoralis major. Major means large or bigger. Pectoralis major are the two muscles that make up the bulk of the chest. The major is here. Now, that is the superficial one. Deep to the major is the minor. Now, the minor, my chest just fell off my model here. I set him down. The minor will be found immediately deep to the major. Now, I've never seen a pectoralis minor on any cadavers look this way before, but this is our book's depiction of pectoralis minor right here. Pectoralis major and minor. Now, here you can also see some of the muscles that we're going to talk about here, like our levator scapulae and things like that as well. And I wanted to put those and mix them in there. Okay, pectoralis minor. Now let's talk about rotator cuff. Now, rotator cuff, I will show these again when I do upper extremities. I'm going to teach them right now, but I will cover them when I do upper extremities because I could not bring the arm model, and I can't show all these right now. I'm kind of limited during COVID what I can bring and when I can bring them. So what I'm going to do is I'll kind of revisit these. But I'm going to go ahead and teach them. And I always say it's the sits muscles. The sits muscles. Okay. And we call these the sits muscles. Muscles of rotator cuff. The rotator cuff muscles, remember, this is sits. Now, sits is supraspinatus, infraspinatus, teres minor. Now, think about a rotator cuff injury is a minor injury, okay? It's not going to kill you if you tear your rotator cuff. How do I know? Because I have one. And then lastly is the subscapularis. Now, the most common mistake is that students will think it is the teres major. It is not. It's the minor. Okay? That is a very common mistake. Now, the rotator cuff are these. Now, I will show you guys teres major again in another video. Let's look at latissimus dorsi and deltoid. Latissimus dorsi or dorsi, latissimus runs laterally, dorsi on the back, dorsal. Latissimus dorsi. Here covered up by part of trapezius, this is the latissimus dorsi, where portions of it is immediately deep to the trapezius, latissimus dorsi. Many of the fibers run laterally, and it's on the back, latissimus dorsi. And the deltoid, which is going to be found here and here. Now let me turn it to the front so we can see it better. The deltoids form the rounded structure to your upper shoulders, the deltoids. Now, I will show these again as well when I use the arm models in my next video that I do, where I'll bring an arm and a leg home with me next. So I'll have the right to bear arms. Okay, I know that's sad. Okay, so here you can see some of these diagrams. Now we're going to go to the trunk, and this actually be where we end today, is our trunk region. Now, the trunk region, we're going to look at the splenius capitis, best seen diagrammatically at first, but I will use the head and neck model to show it. Erector spinae don't have very good models. We only have diagram for that. Rectus abdominis, we have great models. We'll see the tendinous inscriptions in the rectus sheath. Now, the model I brought barely has the rectus sheath on it. The external oblique, the internal oblique, and transversus abdominis. Now, the external oblique and the transversus abdominis will be easy to see. The internal oblique, it'll be okay. The camera I have is better than the one in the lab. The external and internal intercostals actually going to be best on diagrams, and then the diaphragm I can show you here as well. Now, let's start with the splenius capitis. Splenius capitis. Splenius means bandage shape. Capitis tells me it's on the head. So we're going to look at the back of the neck on our head and neck model. And sorry if you can hear the dog bark. Coming from the base of the occipital down here is the splenius capitis. Will be found directly deep to parts of the trapezius. So here and deep to rhomboid minor. Splenius capitis. Next, erector spinae. Now, I said that we would see it best on a model. Diagram. I'm going to show you how deep it is. This is portions of the erector spinae group right here. It's right on the bone, okay? Now, diagrammatically is how we're going to look at this. We're going to look at a diagram from the textbook. And the erector spinae group, there's a bunch of them down here, like down in here. And these are the ones that really cause a lot of lower back pain if you're sitting and you get lower back stiffness. If you sit on the ground and there's some stretches you can do, check out if you have a lot of lower back pain. Check out quadratus lumborum stretch. These are some stretches you could try to do to help you guys with lower back pain if you guys sit a lot. These kind of stretches for your QLs called quadratus lumborum. These are really good lower back stretches. And I have to do those on a regular basis because I sit a lot for my job. I'm sitting here at a computer talking to it. Oh, I just had a spasm in my splenius capitis. Okay. And here you can see the erector spinae group. This is actually the quadratus lumborum right here. All these muscles are collectively called the erector spinae group. Okay. Now, let's turn our attention to the rectus abdominis. Rectus abdominis. Now, rectus abdominis here, your abs. Rectus means straight. Abdominis means in the abdomen. So this is the rectus abdominis. Now, the rectus abdominis, make note, has what causes the six-pack is the tendinous inscriptions. These things here are the tendinous inscriptions. Covering it is the rectus sheath. That's just light powdery paint that covers this part here. Sometimes it is really gray like this, the rectus sheath, which is this collagenous tissue that really adds some extra structural integrity. Then there is an external oblique, internal oblique, and transversus abdominis. Now, I know that because you're in anatomy and physiology, many people will look at you and they will ask you, how is A&P going? Kind of joking with it because they know it's tough and they know it's hard. They're like, how's A&P going? And you're just like, everything is terrible. Well, I'm not just saying this because it is, everything is terrible. I'm also saying everything is terrible. External oblique, internal oblique, transversus abdominis. Outside in, okay? Layers of the musculature. Everything is terrible. External oblique, internal oblique, transversus abdominis, okay? Now, to see this best, I'm actually going to do this. I'm going to take this off my model and start with these. Everything is terrible. And I'm going to zoom in considerably here, and everything is terrible. External oblique, everything is internal oblique, terrible. Transversus abdominis. Everything external oblique is internal oblique, terrible. Transversus abdominis. Okay? Now, the external and internal intercostals, these are associated to the ribs. They're going to best be seen on a diagram here. And I'm going to zoom in on them, and you could see the external intercostals superficial to the internal. And they make double layers on the outside and inside of between the ribs. Now, not the greatest way of actually understanding how these muscles are associated, and on a model, I can only show you guys the internal intercostals here. Okay. Not these guys, as transversus thoracicus. Everything is terrible. Really, rectus abdominis, everything is terrible. External oblique, internal oblique, transversus abdominis. And also you could see it here really well. External oblique, internal oblique, transversus abdominis. Everything is terrible. Outside in. Okay. The diaphragm is really the last thing we're going to be talking about today, and the diaphragm is going to be best seen on our little torso model here. And our little torso dude that we have, our torso figure, this actually isn't a dude because it has breasts, but a very buff lady she is. And separating the thoracic cavity from the abdominopelvic cavity is this muscle right here, the diaphragm. The diaphragm muscle here separates thoracic from abdominopelvic cavity, and that's your diaphragm. Now, the best model that is actually for this, the one that I traditionally always used, was the torso models from our lab because it is large. You can actually see all the hiatuses. Really a nice model, but I do not have access to bring that home. So, this leads us, guys, with, let me double check here. We now have two more muscles. We have 4 muscles today that you're going to be responsible for origins, insertions, and actions. The pectoralis major and deltoid is the last 2. So we have 4. Masseter, sternocleidomastoid. Now let's do pectoralis major and deltoid. And then next class I'll do 4 more. So the pectoralis major, pectoral. Now, it actually comes from ribs 2, 3, 4, 5, 6. Ribs 2 through 6. Sternum and clavicle. Ribs 2 through 6. Sternum and clavicle. Origin. Inserts on the humerus. Right around the intertrabecular groove. It flexes. That means it reduces the angle between articulated bones. It adducts, which means it also brings the humerus or arm closer to midline. And medially rotates, which means it brings the shoulder inward. Like if you were to take your shoulder and shrug it in towards your chest. Okay. The deltoid, origin, clavicle and scapula, inserts on the humerus, because remember the humerus has the deltoid tuberosity. This abducts or takes away the arm from the body's midline. Now, I'm going to tell you guys, there's really no shortcuts on this. It's really just going through and memorizing it. Making flashcards with the name of the muscle on one side, the origin, insertion, action on the other side. And then when you go and you see the name of the muscle, you want to say, okay, origin is blank. Insertion is blank. Action is blank. Then look and check. If you didn't get it right, set it aside so you can redo it. And then also, if you get it right, flip it, put it in another pile. Then when you guys have those cards, now you pick them back up and you'll see origin, zygomatic and temporal bone, insertion on mandible, action elevates the mandible, and you'll go, I don't know it, put it in a different pile to come back to again. And keep doing this so you can kind of have them out like that, kind of cold. When you see it on multiple choice tests, you'll know them, okay? But this is the thing. You need these things for long term. Now, if you're looking at physical therapy, occupational therapy programs that we feed, then you will learn these and then some. You're going to be learning the muscles, the origin, the insertion, the action, the innervation, arterial supply, lymphatic drainage, that kind of stuff. And these are things you'll have to know, and you'll need this as a foundation to build from, okay? But these are the big muscles, the ones that basically that really have, some things. But I think there should be a lot more on there. We used to cover all 119 that we used to learn. We did 119 named muscles. I had to learn a lot more. I mean, a lot of extra muscles as well. So that is the part that we will finish with today. Okay, now next class, I will pick back up when I do the upper extremity. And when I do the upper extremity, I will have the rotator cuff, and I'll actually do the rotator cuff first thing. Then we'll go through the upper and lower extremities. Guys, this concludes my video on the muscles of the head, neck, and torso. Guys, thank you so much. Please let me know if there's anything you need. Don't forget to join in on my office hours through Zoom, things like that if you need me. Guys, I'm here to help. But thank you, and we'll see you in the next one. Have a great day.